Thank you for joining us for this interactive Facebook Live event presented by Siteman Cancer Center based at Barnes-Jewish Hospital and Washington University School of Medicine in St. Louis. Siteman is an international leader in cancer treatment, research, prevention, and education. Ranked among the top cancer centers by U.S. News and World Report, Siteman also is one of only a few U.S. cancer centers to receive the highest rating of exceptional from the National Cancer Institute. Welcome to today's Facebook Live.
Thank you for joining us today for this Facebook Live event presented by Siteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine in St. Louis. Today we're discussing brain cancers and advances in research and patient care. And joining us are two physicians who treat patients at Siteman Cancer Center. To my immediate right, we have Dr. Albert Kim, a neurosurgeon and director of the Brain Tumor Center at Siteman, and also a professor of neurosurgery at the School of Medicine.
Welcome. Thanks for having me. Thank you.
Very good. And we also have with us Dr. Perkins, who is a radiation oncologist at Siteman and director of the Essley Klink Proton Therapy Center. And she also is a associate professor of radiation oncology at the School of Medicine. So thank you again for being here today. We appreciate it. We do want to remind our viewers that during this live event, you're invited to submit questions in the comment section for Dr. Kim and Dr. Perkins to answer later on. And I also wanted to take the opportunity to note that all three of us have been vaccinated against COVID, and that is one of the reasons why we're not wearing masks today. So, turning to you, Dr. Kim, first we wanted to congratulate you on the recent launch of the Brain Tumor Center at Siteman. You, of course, are the director of that.
Thank you. It's been very exciting.
It's a great collaboration amongst of a lot of experts, obviously scientists, physicians, a number of other people who really are on a patient's care team. We're all coming together to advance patient care for brain tumors, and so that's exciting news for you, but also for us and for our patients.
Absolutely.
And we'll talk a little bit more about that later, but first we kind of wanted to get to the topic at hand on brain tumors. And if you kind of help us understand the context of it a little bit, what is a person's lifetime chance of getting a brain tumor? And then how often are those brain tumors cancerous?
That's a great question. So, it's not never. It's not like winning the lotto, but it's also still pretty rare. So the number, sort of from birth to your lifetime, to old age, that risk of getting any kind of primary brain tumor, whether it's cancer or benign, is about a little under 1%, actually. It's like 0.6%. So from birth to, 100 years old. It's not never. It's not, again, like what I would say, like winning the lotto. So, it does happen, but it's not all that common. And then what does that mean, though, when I say primary brain tumor? So when I say that, I mean primary, meaning it comes from the brain. Okay, it's not coming from somewhere else in your body. And there are really two kinds of tumors here. Tumors that arise in the brain, and they form cancers, and tumors that arise in the brain that form benign tumors.
Okay, thank you for that explanation. Now, obviously, not all tumors are the same, and what could you give us an example of the different types of tumors that there are in the brain?
Yeah, so we can again put into two big buckets. So one first, like I just mentioned, is primary brain tumors, and then we have sort of cancerous tumors and benign tumors in that bucket. And then on the other hand, we have another large bucket of metastatic tumors. So, for instance, those are tumors that come from, for instance, breast cancer or lung cancer or colon cancer. Now, in terms of in the total number, probably metastatic brain cancers are a little more common. Maybe we see something on the order of 120,000 cases a year in the U.S. per year, whereas for all primary brain tumors, it's somewhere in the vicinity of about 85,000 new cases per year. Now, the interesting thing about brain tumors, though, is a lot of them are benign. So in the primary brain tumor group, so like I said, about 85,000 per year in the U.S., like 70% of those are benign. So, that perhaps is a little different from other tissues, but just because it's benign doesn't mean it's any less scary also.
Still serious.
Right. Exactly.
And, it's always important for people to know the symptoms. And are those the same for both benign and cancerous brain tumors?
They can be. So the symptoms depend a lot, and I know Dr. Perkins knows this very well too. The symptoms depend primarily on where the tumor is and how quickly it's growing. So, for instance, you could have sort of general pressure symptoms because maybe you have a big lesion that's growing slowly, and that can give you morning headaches, typically nausea, vomiting, and blurred vision. But you might have a sort of one small tumor, but that tumor is in the middle of your motor system, your motor cortex, which controls how you move. So then that will give you weakness, for instance. And as a third example, for instance, if the tumor grows, even if it's small, in your visual cortex, that's going to start to affect how you see the world.
Thank you for that explanation. Now, before we turn to Dr. Perkins, I think a number of people know the different kind of traditional forms of cancer therapy, but for those who don't know, we want to point out that, that one of them is surgery, which of course you're representing. Another one that, as represented by Dr. Perkins, is radiation oncology, also known as radiotherapy. And then the third one is chemotherapy, or also known as medical oncology. So we just wanted to lay that groundwork out there for our patients or for our viewers who are not aware of that. Now, Dr. Perkins, radiation therapy might be the least familiar of those three kind of traditional forms of cancer therapy. How do you typically describe it to a new patient?
Yeah, I agree. I think of the three, radiation is kind of the one people are least familiar with. And it depends on what we're doing. So I kind of like Albert thinking about buckets. There's kind of the traditional course of radiation that we do, which is external beam, which can be done with x-rays or protons. And for those patients, they're going to come in every day, Monday through Friday, for somewhere around 5 to 6 weeks. And treatment takes 20 to 30 minutes each day. Some of our patients are better candidates for radiosurgery, which we do together, which is a single day of radiation, a single course of treatment. But for patients, it's really a non-invasive form of treatment. Essentially, they lay down and their head is held still with a mask or other devices, and then the machine delivers the radiation kind of through the air. And so the course really just depends on what type of tumor, how big it is, where it's located, and so that really varies for patients depending on the diagnosis.
Thank you for that. Now, it seems a number of new radiation therapy technologies have come out over the last few years, and I'm wondering if you might be able to share, the value of those and how they differ from past technologies.
Yeah, I think, here at Siteman, we really have such a great program and have, all of the kind of bells and whistles that you need for radiation. So I think for us, for our radiosurgery program, we primarily use the Gamma Knife system. So that's a system that we use for our patients, often for benign tumors and for those tumors that spread to the brain, like from breast cancer or skin cancer. We have x-ray therapy on our traditional machines, and those are those kind of 5 and 6 week courses. And then we also have proton therapy, so we're the only center in Missouri with proton therapy, and that's a really excellent modality for children and for adults with curative brain tumors as well. And each of those has their advantages, and we kind of look at the patient at the beginning and decide which is the best approach for each person.
I guess the greatest value of having all these technologies is you can really design a treatment for that particular individual. Maybe someone else would need another type of radiation therapy, but that you really kind of make it design it to be what they need.
Yeah, and it's hard for patients. They don't know what's the best, so it's just good to go somewhere that has all the options, so that whatever is out there, this team can provide. And that's kind of what we do in clinic, is decide which place to send each of our patients for our therapies.
You bring up a good point, and what that's sort of known as multidisciplinary care, where experts from each of those different treatment modalities, as they're called, come together and together with the patient determine the best course of treatment. Maybe Dr. Kim, could you tell us about the value of that and how it sort of differs from maybe other cancer centers? Yeah,
no, that's a great point. So in the Brain Tumor Center, we have 4 pillars of care, right, for every patient. It's their radiation oncology, medical oncology, surgery, and clinical trials. And I really liken it to a piece of music, honestly. I mean, whether you like classical music or a rock band, you have to know what the other player's doing. The guitarist needs to know what the drummer's doing. Otherwise, the music is not harmonious. It really isn't the best patient outcome in that analogy overall. And so, as a concrete example of that, if if let's say, for instance, if I were to first see a patient with a brain tumor, I would want to know, based on the likelihood of that person's diagnosis, if there are clinical trials that might be important for that person, and that might include things like during the surgery, I have to take certain pieces of that tumor and give it to a certain lab, and so we can make certain tests available, and really make the opportunity to get a new therapy for that person. So all of that, I mean, again, it's like a piece of music, has to be in harmony. We have to all work together to develop that and to make that personalized treatment plan for that person.
I was just going to say that that really is the essence of personalized care, individual care. Now, I also know that there have been a number of surgical advances of late, the last few years, and I was wondering if you wanted to discuss any of those and what effect they've had on a patient's recovery time. I know many of them are less invasive maybe than older techniques.
Yeah, so surgery, sometimes, some people just say it's cutting, but it's not. It's a form of precision medicine as well, I would argue. We have different approaches for different patients, and it's a balancing act, right? You have to take out as much tumor as you can while you preserve their neurological function. So these are the things we're thinking about when we see somebody. But in terms of sort of the evolution of surgery and what Siteman Cancer Center and WashU neurosurgeons have been part of, I mean, everyone is used to seeing or hearing about craniotomy, where you make a large incision, you take a piece of bone out with a drill, and then you take the tumor out. That's still necessary in many circumstances. But we're part of this evolution where we want to make smaller and smaller incisions through what we would call keyhole approaches. I mean, sometimes it's even through an eyebrow, and the cosmetic result is perfect. And through these small holes, there's less tissue injury, and therefore the patient can leave earlier, and there's less of a footprint on them. Similarly, we use things like endoscopes, which are these sort of James Bond scopes. They're about 4 millimeters in diameter, and we can put them into spaces like the spinal fluid spaces or even through the nose to take out tumors. Again, this is much more minimally invasive. And other things, not only surgical sort of approach related, but if you can't see something, you don't know whether you're going to hurt it or not, right? I mean, that's really important as a concept. And so here we have neurosurgeons like Eric Luthard, who've pioneered advanced brain mapping, and you get this fancy MRI series done before your operation, and then looking at that MRI, we know which parts we should avoid to take that tumor out. And so it's not only the surgical procedures, but also sort of how we see the brain and the tumor. And so all of these things are coming together to really produce the best outcome of a patient. Now, that being said, I do know, especially for brain cancer, surgery alone is not going to cure that person. And so that's why it's so important that we rely on our colleagues in radiation oncology and medical oncology, and we really push the clinical trials to make a new standard of care.
That's great to hear. I mean, what a scary diagnosis, but I have to believe that it brings some comfort for patients to hear that these treatment options exist in one place, that there's a team of doctors with different subspecialties working together on behalf of that patient and finding the right treatment for them.
Absolutely.
Something you said reminded me of the Brain Tumor Center at Siteman. As we mentioned earlier, it just recently launched, and it's bringing together, it's a comprehensive approach, bringing in basic scientists, clinical care, clinical trials, just the whole array of activities going on campus here. What does it mean to a patient to know that exists here? I mean, even at the basic science level, we're learning new things every day. What does that mean for patient care?
Yeah, so I think having a brain tumor center, I think at its very heart means 3 simple things. And so first, it's delivering the best clinical care possible, and that's because I really think we have world leaders, national leaders in each of the subfields, radiation oncology, medical oncology, surgery, neuroradiology, neuropathology, and honestly, if my family or I were to have a brain tumor, something I never would want, I have every confidence that they could take care of my family or me. So that's the first part of it. So it's really expert, nationally leading clinical care. The second is technology, and Dr. Perkins talked very eloquently about this. There basically is no machine that we don't have here. So the cool thing about that is not only is it the most advanced minimally invasive stuff, but it's not like we just have a hammer and everything looks like a nail. We have the entire toolkit, right?
Yep.
So we can use whatever we think that person needs. We don't have a bias. And the third thing is something you mentioned. We have a robust pipeline from basic science to clinical trials, and we are developing the new standard of care, essentially. And there are a lot of people, myself included, who have labs, and we're just trying to discover new ways to treat brain tumors. So I think it's those three things that we're bringing together in the Brain Tumor Center: the excellent clinical care, the technology, and then the science that leads to translation.
Again, all things that I'm sure add a little more comfort to a tough situation.
Yeah, definitely.
Dr. Perkins, obviously the Brain Tumor Center at Siteman includes pediatric care, which you provide through Siteman Kids at St. Louis Children's Hospital. You're also chief of the Pediatric Radiotherapy Service as well. And can you kind of tell us about treating brain tumors in children and how that might differ from adults?
Yeah, I mean, we were talking about stressful situation. To have a child with a brain tumor is incredibly stressful for families. The thing about children is they get totally different diagnoses from adults. There's very little overlap. There is some overlap, but they have their own unique diagnoses. And obviously they need a different approach because of that, and also because of their young age and the stress of things. Similar to what Albert's saying, we have excellent pediatric neurosurgeons, all of the medical oncologists over at Children's really providing the specialized care. And one thing about children with brain tumors is the treatments are very aggressive. I mean, it's very aggressive chemotherapy, aggressive radiation and surgery, and children can tolerate much more aggressive therapy than adults. And what that leads to is really excellent outcome for a lot of children with brain tumors. There have been huge strides over the last 50 years in cure rates for pediatric brain tumors. But it takes, a university and an institution that really has an expertise in that. And I think that similar on the adult side, we have kind of all those necessary pieces from start to finish for the kids.
Very good. I also know, that since children obviously are growing, that's another consideration that's taken into account when you're designing a treatment plan.
Yeah, for children, the brain is obviously still developing. So especially from a radiation standpoint, that's incredibly important. How do you treat the tumor and limit radiation to the normal developing brain? And so most of the children here with brain tumors are treated with proton therapy for that reason. Protons, I've been throwing these terms around, but X-rays are how most patients receive radiation. Protons, if you remember from chemistry, are positively charged. So they're heavy and they have a charge, and what that means is that you can control where they go in tissue, how deep they go. X-rays, you can't. They go and they exit, and that's why they're good for imaging and things. So for children, protons are really important because you can control the depth, and that means limiting radiation to their pituitary gland, to their temporal lobe, to other areas. Because really our focus, as soon as we we're on the curative approach and things are going well, what about high school? What about college? What about lifelong effects? And so that's, really right up there as top priorities for the kids.
I mean, as in both cases with adults too, you're not just treating someone for today, you're treating them for the rest of their life in a sense, in how you design the therapy and
Right.
the kind of care you provide. I think it's important to mention too that with children, we also have child life specialists who really kind of, I don't know if angels are the right words for them, but they certainly have a really special place in the care of children. Could you explain how they help?
Yeah, so thinking about, that 6-week course of treatment, the child's coming in every morning and getting radiation. One of the things that we really focus on is reducing anxiety so that children can complete the treatments without sedation. So child life is really critical. They read to them, they tell them jokes, they give them toys. We actually have an apparatus now where the children can watch TV while they're getting treated, and that's been huge. So we had a 4-year-old get through treatment with no sedation, and I'd say 2 or 3 years ago she would have required anesthesia for 6 weeks. So they are complete angels. One of our problems is that they don't want to leave when their treatment's finished. So their treatment's finished and they don't want to go, which is really great. They're having fun and they tell the parents, "Is it Monday yet? Like we're ready to go back." So that's been really cool.
There are a few things that you do that I think are kind of extra special in that, I know on Proton there's a mask that they have to wear.
Right.
But the child life specialists help them paint them. And I know kids in the past have gone into the Proton therapy room dressed as Superman.
Yes.
And, really kind of giving them that extra edge they need to be strong and get through that treatment.
Yeah, it makes a huge difference, instead of that sterile medical environment, and so we've had so many child life specialists over the years, and they're all so wonderful, really, really critical to our mission.
Very good. Again, another point about personalized care and really delivering what an individual patient needs
Right.
at that time. So that's all of my questions, but we do have some viewer questions here, and one from Bethany is this: how often does gamma knife radiation or other forms of radiation on a non-cancerous tumor result in dangerous swelling, Dr. Perkins?
Yeah, so Albert and I treat a lot of these together. It just depends on I'd say size and location. We kind of keep going back to that. I tell patients there's kind of high-priced real estate and low-priced real estate. That's probably not how Albert described it.
No,
but,
I do say that too.
It just depends on the location, and that's something that we monitor. We tell patients to let us know of any side effects, and then we're also getting scans to assess. Sometimes we can see that swelling before it's even causing symptoms for patients, and there's quite a few treatment options for that if it happens.
Very good. Bethany has a follow-up. She's asking what rate of growth is considered fast in a benign meningioma?
Oh yeah, actually, no, that reminds me. I should say something about what are the most common tumors out there in the brain, and it's something I didn't talk about. So the top 4 tumors, just before I get to your question, are meningioma. So that's the most common primary brain tumor, like 38%, followed by pituitary tumors, actually, at 16%. So 1 out of 6 are pituitary tumors. Third is glioblastoma, so the disease, the brain cancer people know about, the one that Senator McCain had, that Ted Kennedy had, for instance. So that's the one that everyone's trying to beat. And then the fourth is a little less known tumor. They're vestibular schwannomas, actually, or other sorts of nerve sheath tumors. And so those are the top 4, I would say. So Bethany's talking about the most common among those, meningioma, and we do often use things like gamma knife radiosurgery and things like that for this. And so what was her specific question?
She asks what's considered a fast rate of growth if they're benign?
I think it's somewhat relative. I would say any growth or any symptoms that cannot be easily mitigated would be a tumor that I would consider for treatment. So I think it's a bit relative. The other tricky thing about it is, we're not used to thinking about volume, so a small change in diameter or radius on an MRI may actually represent a huge change in terms of volume, because it's, if I remember my math from high school, it's like the cube of the radius, right? So the volume can actually change a lot more rapidly than you think.
Okay, thank you for that explanation. The next question is, does long-term low-dose chemo typically work for controlling growth in benign meningioma, or is radiation and or surgery more effective in treating that disease?
Yeah, so we do. I saw a patient last week that I share with one of Albert's partners that has multiple meningiomas that she's had since a child, and so we did send her to medical oncology because the terrain is always changing, and so that he did actually have a few recommendations for her. She's young, and right now we're just kind of watching things. So we don't often do systemic therapy for meningioma, but it is a possibility for patients that have like a single. We're probably doing radiosurgery or surgical resection more commonly. Mm-hmm.
Very good. We have a question here now from Kate, who's asking, what causes brain tumors to develop, and is it more common for them to be cancerous or benign? We sort of answered that, but let's certainly answer it again.
No, so if we're talking about primary brain tumors and not a cancer from somewhere else in the body, actually probably many of them arise as a result of a mistake in how cells divide. So, again, so there are lots of things out there where it's obviously related to a behavior. Lots of cases of lung cancer, for instance, obviously related to smoking, right? For instance.
Although not all cases.
Not all of them, but many, absolutely correct. But there's a clear subset of lung cancers where the smoking is related to the cancer. But it's not really the case in brain tumors. I mean, there are a few correlations, I would say that the two that I'm aware of, one is that if you have sort of atomic blast level radiation or sort of maybe really high dose radiation early in life, that can predispose you to meningioma, for instance. And there's actually negative correlations between having some kinds of like allergies and things like that with gliomas and glioblastomas. But otherwise, it for the most part is because a population of cells that are normally just dividing your brain made a mistake during division, and then that makes a mutation or a change in the DNA, and that gives that cell an advantage to grow faster, and then that's propagated. So in most cases, I would say it's that latter scenario where there's just a mistake made during division.
Okay,
Yeah.
thank you. We have a question here from Larry who's interested in the research, and he's wondering what research advances are still needed to improve brain tumor survival rate. I might also add, a question that I have is, what are you most excited about that seems to be on the near-term horizon as far as research is concerned?
Yeah, there's a lot of things on the horizon. I mean, some of them are really cool new technologies in radiation oncology. Things that are related to proton, but you can do these treatments faster, something called FLASH, and I don't know very much about it, but these could revolutionize treatments. And then there are other technological things on the horizon, like focus ultrasound, where basically through skull or maybe through a small hole in the brain, you could change the environment of the brain such that drugs can get into the brain because they usually don't. Or you could even use that focus ultrasound to kill tumor cells. So there are things that are just sort of right on the horizon and that are really technology driven, that are interesting. But then there are other things, I think, that are coming down the pipeline. Sort of the things that we're thinking about here are things like immunotherapies, for instance. Sure, they haven't worked great yet for things like glioblastoma, but I'm very hopeful that version 2.0 will work even better, for instance. And we're thinking about precision medicine a little differently. It's not just the mutations and things like that, but it's also how your DNA changes with therapy over time, something we call genome dynamics. And then finally, again, we have some devices here which are really interesting. I mentioned some of them, laser and focus ultrasound, but it's not only about killing cells, like I said. It's also about opening a blood-brain barrier to allow medicines to get in. It's also about changing the immune environment to make the immunotherapy better. And so I think all these things are coming down the pipeline. They're exciting.
Very good. Dr. Kim did mention FLASH technology, and I know that there's a recent announcement out of the Proton Center that we are currently upgrading the technology to include that. Could you speak a little more about that, Dr. Perkins?
Yeah, so FLASH is really, and FLASH has been around for decades, but kind of went away and is back. But typically when we treat a patient, the treatment delivery would take somewhere around like 4 to 5 minutes. So you're giving all that dose in that amount of time. And again, a small dose every day. I kind of tell patients it's like a building block. With FLASH therapy, you give all of the dose at once in like less than a second. It's like 1/10 of a second. And the preliminary study, so most of the time when we start really early, we start with just really basic science research, not even in humans, shows that it appears to kill cancer, that's great, but also is not affecting normal tissues like brain and bowel and skin and other things like you would expect with such a fast delivery. It may have to do with oxygen depletion and all this like very complicated radiochemistry, but it's something we're really interested in, and our particular proton machine has the ability to do this delivery because of the way it's engineered. And so, to be here in the middle of this rich scientific community, we really have all the pieces to kind of answer like what is going on and what does it mean in the brain and what does it mean in the pancreas. So it's a big research priority for the center.
Very good. I know a couple of pieces of technology over the last 5 or 6 years were sort of developed in concert with the radiation therapists here, and then obviously the maker of those technologies. Can you speak to what occurs here, what characteristics about this place make that such a great combination?
Yeah, I think for our department, we had 2 milestones actually the same month of the same year. Back in 2013, we were the first center in the world to have a single vault proton system, which was incredibly important. You can see from our campus, like we don't have room for a football field size machine. We wanted a small machine to put close to Barnes and to Children's. And at the same time, we were the first department to do MR-guided radiation. And so, you know, when two companies come at the same time to do this, it's because of the productivity, the ability to take it from, you know, a concept to humans. And it's just really a strength of the department, and both of those programs are really strong. We're going to have our second machine opening up next year for proton therapy. And it's just all those pieces Albert's talking about. You know, it's all the research, all the science. For us, it's major support from our physicist behind the scenes to take this new technology to our patients.
I think it really shows the real commitment, though, of individual physicians and researchers, but also of the institutions here as well, to have that kind of commitment to help develop therapies, to help develop technologies. I mean, it really speaks to, you know, what drives, you know, this academic medical center to help patients today and into the future.
Absolutely. I mean, a lot of people have to be on board for us to buy, two proton devices. I mean, it takes a lot of people with resources coming together.
Very good. We have a question here from Kyle, who's asking if there's a predominance of brain tumors in a certain gender or age group and/or ethnicity or race of people. Are there any groups that are maybe more predisposed to getting a brain tumor than others?
Yeah, that's a really interesting question. It depends somewhat on the tumor type. So, for instance, meningioma, which again I said before is the most common primary brain tumor, again mostly benign. It has a sort of a predilection for females and in middle age, for instance. However, if you have a more aggressive meningioma, like some are cancerous, they're rare, but some are, then that's more likely to happen in a older male patient, for instance. Let's get back to the example of GBM, which again is a terrible disease. You know, we're obviously fighting to do better for these patients.
And that's glioblastoma, correct?
Yeah, I'm sorry, glioblastoma. And for that disease, there is a slight male predilection, maybe, 1.5 to 2 to 1. So males get it slightly more, and males also tend to do clinically worse who have that disease, that glioblastoma, for instance. I mean, again, other tumors may be different. Some actually have no predilection for a certain sex. Others do.
And for children, there's a slight predominance for boys over girls. And one of our researchers here, Dr. Rubin, is studying why that would be. You know, we grow at different rates, men and women in puberty. And so taking that clinical observation, you know, into the lab, what is it that makes the boys more likely to develop? It's not like 10 to 1, but it's consistent across the decades.
You know, what's really clear to me hearing both of you speak is the complexity of everything, you know, behind a particular treatment or a particular patient, and how it really takes all of these pieces to come together to even have a brain tumor center at Siteman, but more importantly to be able to treat each patient in a way that will be most beneficial to him or her. Mm-hmm. It's clear from what you say and all the examples that you're using that this is the type of care that you provide here. We do have a question here from a viewer named Chris, and she's wondering if a child receives proton beam radiation for craniopharyngioma, and forgive me if I mispronounce that, what is the expected outcome on that tumor long term, and is it expected to grow back again?
Yeah, so craniopharyngioma is one of the common diagnoses that we treat in children with protons, and you know, the outcome for those children is really good. There's been a little bit of a shift more towards more limited surgery or biopsy for the kids. In some cases, they are surgically resectable, which is great, and that's the only treatment they need. And then if it can't be removed, you know, safely surgically, then protons is the definitive treatment, or radiation. Here we would use protons. And, you know, the vast majority of kids do really well with that diagnosis.
Always encouraging.
Yeah, I would totally agree with that. The new stuff that's coming down also down the pipeline is precision medicine for craniopharyngiomas. So there are certain mutations that are associated with certain, particularly in kids craniopharyngiomas, and they're now medicines that are coming out for these kinds of craniopharyngiomas. So that'll be an interesting in the next few years.
Always on the hunt for new and better therapies, right? Better outcomes.
Definitely.
That is all of our questions from our viewers. So I want to thank you both for being here. This was a very enlightening discussion, and I know that a lot of good information has been shared. And we, of course, want to thank our viewers and to invite you to follow Siteman's Facebook page to learn about future educational events like this one. Thanks again for joining us. That was
Thank you.
fantastic.